All right. Well, hey, thanks everybody. I'm going to say one quick thing and then turn the reins over to Cedric here. Thanks for joining us for the Extracorporeal Hour. For anybody who's new to these sessions, Cedric is out at UC Davis in San Diego, and I'm out at Cornell, and we're running our respective extracorporeal therapies units. And this is an hour session every other week where we get together to talk about cases that have gone well, new things we've discovered from, well, I'll put it in my own terms, learning from my mistakes and learning about what other people are struggling with or have found learning opportunities with. And that has led to Cedric putting together today's session with a couple of invited guests to talk a little bit about the apical toxicities that a lot of us are seeing, both in and out of the extracorporeal world. So thanks everybody for being here. Join us again in 2 weeks. And if you have an interesting case you'd like to chat about, come with a presentation, come with an idea, just share. It's open for discussion. As always, we love to see faces. So for those of you guys that put your cameras on, it's great to see you. And with that, we'll just make it an open discussion, but I'll let Cedric take it over from here.
Yeah, thank you, Jethro. Yeah, I'm not gonna waste too much time because I can't wait to hear from our guest today. The idea for this session just came up in the last few months because I was getting more and more calls about apocrine toxicities at our unit, either for decontamination with hemoperfusion or for dialysis because the patients were already having acute kidney injury. And I really felt like these calls were getting more and more frequent. And Full disclosure, I haven't treated one of these cases myself yet, but I knew that some people had done that, and that's why I invited Emmanuel Buty from Tufts and Tyler Johnson from NCSU today to share their experience. And I should apologize. I think there's some other people that have treated those cases, and I just reached to the people I knew had some information on that. But if you have treated some cases, feel free to join the discussion and bring your experience as well. Because again, the goal is that we all learn from the cases we've had in different centers before our data its publication. Looks like Dr. Lister just published a recent communication and that there's more to come in the JDEC. And I'm sure some other people will publish their cases as well. But yeah, will be able to say that you heard it on the Extracorporeal Hour first. I'm gonna turn to, I don't know, Emmanuel, do you wanna start maybe?
Sure. I guess, yes, because theoretically, I'm sort of the first part where when we may intervene early enough, and then Tyler can take over for the when, unfortunately, things are not happening the right way. Let me. Yes, so I guess I can very quickly introduce myself. Hi, everyone. I'm Emmanuel Buty, in charge of the extracorporeal service here at Tufts. And so funny enough, we've treated two cases of apoquel toxicity the day before NC State posted their big warning on their website. So it's always funny how the timing of things, right? I should be able to share. Okay, you're able to see my screen here.
Yes.
Terrific. Okay.
There you go.
So, without further ado, I just added a little blurb here on Apoquel because, like, for every toxin, like every time we reach out about potential extracorporeal therapies for different drugs and toxins, we always sort of quickly look at what is happening and how they behave in the body. And so, as probably everybody knows, Apoquel is this JAK inhibitor that is used for the management of pruritus in dogs, also used in cats, but off-label. We have these different oral tablets that are available, and the difficult part with this medication, it has a very short half-life and time to peak concentration. If we focus in cats here, we can see that the Tmax is 35 minutes only, and the half-life is about even less than 2.5 hours. So, at least at the therapeutic level, it's a very short acting. And of course, that always makes it hard to intervene early on. early enough in time after ingestion. The molecular weight is quite small, 450 Dalton, and kind of a low protein binding, around 66 to 69%. It's interesting from this study that shows, like that describe the multisystemic consequences of apoquel overdose. They sort of highlight that pit poison has seen a 300% increase of overdose since the chewable, like option is available. So definitely, like the flip side of making things easier to give, we definitely see more risk of overdose. And so the mechanism of the toxicosis is still kind of a lot of question, but there is a couple of thought process. So do we have an issue with an excessive blockade of the JAK enzymes, perhaps decreased selectivity, or this theory that there is an excessive JAK inhibition at the beginning or during, like the overdose. And so this disinhibition cause sort of this rapid release of cytokines and interleukins associated with JAK1. And so do we have this transient cytokine storm that cause all this clinical signs that we are seeing in sort of the midst of it? That's sort of all the suspicions that we have here. And so that's sort of the main article that I used when we got this two cases showing up. That was, very interesting, describing the multisystemic consequences of apoquel overdose in dogs and cats. And so it sort of described the lowest reported doses before, seen with adverse clinical signs, being around 10 mg per kg in cats and 12 in dogs. And the typical clinical signs that you definitely probably have seen if you've handled these cases, but the neurological changes with lethargy, but that can really go up to trembling, ataxia, and lateral recumbency, depending on the severity. GI signs are very often the first ones that are noted, and maybe the reason for presentation, which is super vague: vomiting, anorexia, diarrhea, and hypersalivation. We can have really bad cardiovascular changes with tachycardia and hypotension, much more frequent than also reported hypertension, bradycardia, and murmur. But at least in my experience, that's really the severe hypotension that I've been seeing. And because of all the inflammatory changes, and I've seen also ocular changes with very bad uveitis, and interesting cases that we gave intralipid to. So we really had lipid deposition in the eye as well. So sometimes things that can look quite impressive. Mainly reported in cats, and things that we're for sure going to discuss, but acute kidney injury and liver injury and leukopenia has been reported as well. And this is the two offender we'll be talking about today. So they showed up August 4th, 2025. They sort of had an apoquel party between these two cats and two dogs, where the total dose was 80 tablets of 16 milligrams, so a total of 1,280 milligrams. So highlighting, again, what we generally have on the clinical floor, right? We have no idea who ate it, how much, we don't know when exactly, but that was suspected to be about 8 to 10 hours ago that these two cats were, ingested that. And this first one here actually presented before they even noticed that the apoquel were gone. That's how the story started. This 12-year-old female Spain Himalayan was presented to the referring veterinarian for just vomiting and diarrhea. And then everything went downhill, started to be neurologic, severely hypotensive. And when they went home, they realized that the apoquel was missing. This other cat started to show clinical signs as well. And that's how all things got figured out what was happening. And so these two cases were referred to us for potential, management, with extracorporeal therapy. And so starting with this little one here first, and of course, don't hesitate to jump in if there's any questions or comments. This first 12 years old female Spain Himalayan was so tiny that we were concerned that with hemoperfusion, and I'm not sure if somebody is not, are you able to hear me in the background? I can sort of hear myself. I don't know if somebody's not muted. Okay, so this first case was so tiny, with even with our hemoperfusion setup, that was, I think, about 35 or 40% of her blood volume in the system. So we sort of MacGyvered and that has been already published, but sort of this manual way to do hemoperfusion. And so we sort of created a circuit like that, trying to really decrease as much as possible our extracorporeal volume. We still blood primed the system, but we were down to, I think, 15% of the blood volume using basically extension sets that were even cut, and sort of then using female to female lure to adapt all the three-way stopcock with these cut extension sets. And so with that, we were able to have the smallest system possible. We used a regular lumen. The cat was too small for even the smallest dialysis catheter that we had. And with that, we sort of, blood primed the circuit and used our 10 cc syringe as sort of as our blood pump to pull 8 ml at a time, which was about 5% of the blood volume, and sort of go around, and push that in more hemoperfusion during the entire treatment. The hope was to do at least 5 blood volume. We were unfortunately only able to do 3.5 before the system clotted. And so, and this, treatment, both cats probably had their treatment happening about 12 to 15 hours after their suspected ingestion of Apoquel. So that was the first one.
Before you move, yeah. Oh,
Yes.
well, you were about to talk about anticoagulation. I just saw the heparin syringe pop up. That was my
You see
question.
my amazing, I was very proud of this terrifying add-on, but just making fun of myself here. But what we did, we use, systemic heparinization. I added that here because, like rethinking the process, and maybe what we should have done, instead of giving heparin directly to the cat, we could have sort of, again, MacGyvered a heparin steroid directly prior to the hemoperfusion column, trying to perhaps decrease the risk of clotting. This cat was running at an ACD of between 200 and 250. And despite that, as we all know, cats love to do whatever they want. And so, and of course, it was not a normal, like constant flow that was constantly back and forth. So we were very concerned about this to happen, but we tried to do our best with the situation that we had. And so,
Somebody in the chat is asking, was that cat already symptomatic when you treated it?
yes, it was really quite neurologic, kind of like lateral recombinant. Started to improve during the treatment, which was very interesting. We needed to use our cat bag because it started to, like being back with us and trying to fight us. And so ended up in the cat bag. But yes, we placed the catheter without any some form of sedation, and he was really out of it until sort of mid-session. So we had run only, I don't know, 2 blood volume at that time, and it started to wake up and fight us.
And I see that the ingestion was 12 to 15 hours prior.
Yes.
Was the cat already azotemic when you started the treatment?
Yes, was already azotemic. I'll have to circle back to that. Maybe I don't have the exact number for this cat, but yes, was already azotemic. Not terrible, but already azotemic. And so that's what happened with the first cat. Long story short, unfortunately, despite the treatment, the azotemia worsened. And because of the rapid decline, the owner decided to stop. So we don't have a great outcome for this first case. And we'll have more results from the necropsy for this one.
There's kind of 2 questions that come up here, I think. One, for me anyway, there's one in the chat from Erica Penn, who was asking about the choice of carbon versus the vet rescue device.
Yes. Literally the only reason is because, again, we have no data for any of those. So that's mainly because we have more experience with the carbon. So I have no real way to say why we use one or the other. So I cannot say, oh, we use that because it's more efficient. That since we have 0 data, that's literally the only reason why I use the carbon.
Well, I think the other thing your decision to treat here at the 12 to 15 hour post ingestion mark is, when is that window when we can make
Hmm.
a difference? And I
Yes.
think that's part of what we're still learning. So I think I I don't know. I had a dog who was at about 15 hours post and did have some cardiac arrhythmias and some signs along those lines, and we didn't treat that dog.
Hmm.
But your description of this cat showing some at least some clinical improvement even at that point.
And I have better,
Yeah,
more to
yeah.
come.
Oh, great, great.
More
Awesome.
to come. So this is the little, yeah, regarding that. I don't know if you have any other comments because I have more to come for that particular comment.
Yeah,
Um,
but just a question from Joanna asking if the cat had corneal edema or uveitis.
both, both. So that was, yeah, very something quite significant. And with the uveitis on top of definitely had evidence of, inflammation, but also because this cat had received intralipid, that was even more so impressive clinically. I'm very sad that I don't have a picture. But, the next day, yeah, his eyes were white. So that was very impressive. But that was not these two. That was a third one that I'm going to talk about. This is the other cat that we treated, sort of conventional hemoperfusion with the machine. We also blood primed, and the treatment went very, we were able to have a dialysis catheter. We were able to use regular hemoperfusion with a constant flow. And so the treatment went much, much more smoothly than this 2 kilo cat. Still blood prime the system. What I've learned from my mistake is I used to blood prime with packed thread and saline when the extracorporeal circuit was so big, compared to, and we really run into this issue a lot with cats. And so I used to blood prime with pack red and mixed with saline to have an hematocrit not too high. But I've really learned from my mistake, especially when a large amount of their volume is in the system. They do well for 20 minutes and then suddenly they crash down, and so most likely because all your crystallaries are out. And so since then I really blood prime, sort of recreating whole blood from plasma and packed red, and they're much more stable with this, at least in my experience.
Yeah, I
And
would
so
also add just like for blood prime on the carbon, I noticed too that if you don't heparinize your blood prime, there's a fair chance that that's going to clot before you would stop the patient.
mhm.
I don't know if that's been your experience too.
To be honest, generally we finish the blood, like we sort of have everything ready, we
Yeah,
blood prime and we connect. So by like it basically
yeah,
generally is in the cat with cats I tend to have my ACT really never below 200 when I start, because I know that despite that some clots and that they're really a pain in the butt. So I tend to run my ACT really on the safe side. The more experience we get from these dogs, we tend to be a little bit more ballsy with lower ACTs, but cats I never give
yeah.
them any reason to clot because they are going to do that on their own no matter what. And sometimes they clot while the RCT is 999. So they are very interesting creatures. And so, yeah, that's the funny thing. Well, the next day people were like, oh, actually you saw, and C-State also saw cases. And so that's the funny part where we try to intervene with hemoperfusion even before or, while the AKI was happening, while we'll have more interesting talk about what can happen once the AKI got so bad. But circling back to Jethro's comment, this is the most interesting part of my talk because we were able to get concentrations before and after the treatment for each cat. And so with our manual hemoperfusion, and 3.5 blood volume, we definitely did not reach a great, as great of a reduction as the regular hemoperfusion that we did for the other cat. But two things very interesting, or at least two things very interesting. I think that definitely we have evidence of improvement. But also what is very interesting is how high the levels were even that long after the exposition. So highlighting the fact that how, very abnormal the pharmacokinetics are when we have overdose. And so it may be still worth it treating, even if it's hours. And despite the half-life being so short, if there's still clinical signs, I would argue that perhaps it's still worth it intervening at that time. And that's the results of the necropsy. And I don't know if Rachel, I know we told her that we would be talking about that today.
Yeah, Rachel is connected.
Okay. But because definitely I'm not going to steal her, her work here. And so we sent one of them, this young this 2.7 cat was sent to necropsy. And so this is the results of this cat plus the results of another cat that we got from another practice that was never referred to us, but we were able to get the body donation to have necropsy from this cat as well. And so the common finding is really the severe tubular necrosis that happens in these cats that get an overdose. So these are the necropsy findings. And very quickly before I give I give away and I stop bothering everyone. I just wanted to present this case here, a 3-year-old male domestic short hair that was referred to us for renal replacement therapy because he was getting worse and worse. He was really, really bad, like on 2 different pressors and his azotemia was worsening and the owners wanted to do absolutely everything. So got referred to us. But by the time he got to us, his blood pressure normalized tremendously. And this was, like his original urinalysis highlighting, the really bad tubular disease. The USU was not too bad at that time, but definitely 3+ protein, 4+ glucose, without any evidence of active sediment. And the cystatin at the beginning was 420. And so that's a case that was referred to us for renal replacement therapy. We were sort of ready to go in this direction. He presented 24 hours after, or almost 24 hours after ingestion. So I told them that at that time, even if we knew that after 15 hours, we still had something, like 24 hours, I was like, this is probably a stretch. And I'd rather have the money for your renal replacement therapy rather than spending the money on hemoperfusion, not knowing how much it's gonna do for him. So that was the plan, keeping the money for the renal replacement therapy when that would be required. But thankfully, he decided to choose the right road. And so his creatinine at his worst was 3.1 and then decided to improve by himself. So all of that to say, I wanted to present this case because, again, was on 2 different pressor, looked absolutely terrible, and was azotemic. And so we were just waiting for him to get worse and start renal replacement therapy. But some of them can survive and overcome this overdose. So all of that to say that I wouldn't give up even if I don't have access to renal replacement therapy. And that's all I had for you, I think.
Well, thank you, Emmanuel. I have one question. I probably was not paying attention at that time, but in what time frame did you treat the second cat that had the 93% reduction?
Similar. They sort of arrived at the same time. And
So that was same household, so
same
12 to
household,
15
the same party of
Interesting.
Apoquel. And so the first, it took 12 to 15 hours because the first cat was presented with just general GI signs and, started to become neurologic and hypotensive. They went home and they realized that the Apoquel, the Apoquel was torn apart and they had 2 dogs, 2 cats, and the other cats started to show GI signs as well. And so that's how everything started and everybody got referred to us.
It's very interesting because like based on the pharmacokinetic data, right, we would think that at 12 to 15 hours we wouldn't do much. And again, it just highlights the fact that the pharmacokinetic data that we have is for like a normal dosage.
Mm-hmm.
And that for like huge overdose, we may have a different volume of distribution, a different half-life of the product. And so well, sometime when we don't have the data, we need to try and see if we can do something, even if on paper it doesn't seem to be the best idea. So it's really interesting that we have those numbers, have those concentrations, and show like a good reduction. even like that late in the process, I think.
Yes, I wanted to circle back to that while you're talking about that, because we can go back to, since we're talking about the characteristic of the drug, um, here, because why it keeps doing that? Um, I'm just gonna not show you in presenter mode. So if we go back to the characteristic here, are you seeing my screen?
Yep.
Yep. Good.
Like the one of the thing could be also, like it's a small molecule, it's a, kind of a low protein binding. So, like that could be also a case where we could even combine hemoperfusion and, like hemodialysis to try to remove as much as possible. Especially in cats, what you run into, of course, is the size of the circuit, right? But that could be something that if you don't have an hemoperfusion and you just have hemodialysis, that could be, still a case that could be interesting. I don't have any data, but all of that to say that it's not hemoperfusion only, because I think there is a decent amount that we can remove, and especially that maybe, that maybe even sort of even more skewed if you really have an overdose regarding the protein binding. So yes, that's the one thing that I wanted to say. The other thing, I think I got asked where the sample got sent, but that was Michigan State University where we sent these samples. I think that got asked in the chat. Yeah, Michigan State.
Yeah. I think the other thing that Jay brought up in the chat as well, and I think it was something I was jotting notes down. I think on the slide that you had before here, a couple before anyway, the cytokine storm,
Mm-hmm.
proposal.
Mm-hmm.
Looking at the carbon, Cytoclear, the Echo formulation versus Dublin for Toxiclear versus the vet rescue device, and kind of trying to weigh out the pros and cons of those things based on that cytokine storm theory.
Exactly.
And I think probably to the point that or the answer that we often give to that question is I think we need more of the data to try and determine which one may be the better way to go. But did you guys use the Dublin or the Toxiclear formulation of carbon?
I think that was the Dublin at that time,
Yeah, makes sense.
because that was, yeah, August 2025. Any other questions or
Yeah,
comments?
there's one question in the chat asking how long was the second cat total hospital stay after the hemoperfusion?
It still developed an AKI, so I think that was just the time of, improving his AKI, but I think that was something like 4 or 5 days after the hemoperfusion treatment. So because of the delay and, like the overdose, and, like while we have the second part of the presentation, I can circle back to make sure that I'm not telling you any mistake. But from what I remember, I think 4 to 5 days. He didn't, that's not the type of case of, I don't know, your NSAIDs that you can completely remove and the next day, we avoided the AKI and they can go home. I think that here, because of the mechanism of the drug, it's going to be extremely hard to, sort of the time that the owners realize that happened. And I think that may be harder to avoid the AKI compared to the most common toxin that we see causing AKI being NSAIDs.
Yeah. And before we ended up to Tyler, like there's a couple comments from different
Yeah.
people in the chat
Yeah.
that they had experienced that some cats fully recover in 2 to 6 weeks despite severe azotemia and without
Mhm.
treating, without being treated with extracorporeal therapies. So
Yeah. Yeah.
just like we see, I think with acute kidney injury in general, right? So there's
Exactly.
always a way to go.
That's why I wanted to highlight with this third case, because we were just waiting to go and turns out he decided to fix himself. So this case can happen.
All right. But in some cases, they might be actually anuric or severely azotemic and need to go on hemodialysis. And I think that's where Tyler has some experience with some cats, and he can elaborate on that, right?
Yeah, this one was like we've actually had similar experiences with Emmanuel. We've now attempted decontamination in one dog that we're hoping to get like more information on from that. But the cats that we saw, actually, we got both of the cats. They were young cats. One was 3. The other one was a year old. Both got into the dog housemates, Apoquel. One consumed about 36 mgs per kg. The other consumed about 54 mgs per kg, and presented to us as referral following severe AKI that developed over the course of like 2 to 3 days at the referral hospital. What's interesting about these two cases is like the first case that we saw, this was like March of last year, actually had a developed a severe hyperkalemia, like greater than 12 over reference interval at the referring center. On our recheck, that was the same, like it was greater than 10 for our reference interval. And in spite of medical management, where we like took the cat to IHD, he was still like greater than 10. And initially was very bradycardic, cold, hypotensive. They treated him as you would for a hyperkalemic patient, and then developed like tachycardia and became very tachycardic, like 250, that was sustained until after our first session of IHD. And so at the time, we had just gotten our Carpe Diem, and we didn't have a different, like, smaller circuit. So we decided to actually put this cat on the IHD circuit, which was a bit of a pain in the butt, but we just wanted to remove potassium as fast as we could. And the cat did really well. We achieved like a little over 50% URR, but we're able to treat his potassium pretty significantly. And what was also really interesting about this case is this cat developed a CK on presentation to our hospital, because we didn't have any of the info from the first patient or from the first clinic. His CK was about 100,000, that then progressed to 189,000. And at the point that his CK jumped up to like the 180,000 range, we added in that rescue column to our IHD prescription to him. So that was the second session for this cat. And following addition of that rescue column, like this cat started making a lot of improvements. So initially they were concerned that he was anuric. That was another part of the reason that he was referred to us. And by his second session, he was producing around 2.2 mils per kg per hour of urine. And we had fixed a number of his things. We ended up treating him a total of 4 times. And he was really nicely polyuric and had plateaued with a creatinine of about 2. So that was about 2 weeks worth of treatment in that patient. But we treated him 2 times with the cytosorb column. And I think like each time we saw a reduction in his CK really nicely. And he seemed to have much nicer improvement in kind of what we were seeing as far as his AKI goes, and his rebound, right? So it was like pretty interesting as far as that case goes. The other thing we noted in this cat is that he was also pretty profoundly hypophosphatemic, with a phosphorus of about 1 on presentation that then dropped. So we actually had to give this cat phosphorus, which was like odd. And then in contrast, the second cat that we treated followed similar illness script from a cardiovascular renal system, except that this cat never developed hyperkalemia, but had a pretty profound azotemia with BUN greater than 140, creatinine like 8. And this cat was treated because his potassium was appropriate. At the time we started treating, we did like a PIRT session on him over about 8 hours, and he did really well with that. But the big thing for him is his like CK was perfectly normal, never ever went elevated, and he was pretty profoundly hypocalcemic with a ionized calcium of about 0.7, normal phosphorus, which was just like odd. This is second cat had consumed like 54 milligrams per kilogram um of the drug, and then it was kind of wild because both cats like got four sessions. By the fourth session, they were normal. Well, not normal, but polyuric, recovering, had stable renal values. And both cats, as of like 2 months post, had perfectly normal renal values in total. So, and we did these animals kind of before we had much more information. And we recently saw a patient that consumed about 90 milligrams per kilogram of Apoquel. And what was interesting about that case is the client at that this was like in I want to say November of last year, and it was kind of crazy because the cat actually self decontaminated on the way to the vet and like vomited all over the client's car. And then at the vet, they induced emesis again and administered activated charcoal. And then the cat was referred to us for like continued decontamination. We actually decided to wait because the cat presented pretty appropriate. She did develop a very mild AKI over the course of like 24 hours with the creatinine going no more than 2, and then was discharged with normal renal values on day 3, day 4. So it was kind of interesting that the coincidence of this cat like vomiting in the car and kind of self-decontaminating and then getting like really very early decontamination really mitigated a lot of signs and effects for this cat. We've also similarly, we had one recently that had a really significant AKI about 12 hours following ingestion that had really profound hypotension, bradycardia, and that was euthanized, had necropsy, also had an acute tubular necrosis. But it's just interesting to me, like how varied some of these cases can be. Like neither of our cats had ocular changes except for raised third eyelids. The second cat that we treated had a very mild neutropenia, like 2000, and the third cat was normal, but the fourth one that ended up euthanized had a profound neutropenia of about like 600 neutrophils in such a short period of time following presentation. I think that cat ate around 50 mgs per kg as well. I think that's the biggest thing for me. I'll say there's hope, right? Like we were able to treat both of our 2 cats with hemo with IHD and PIRT. The second cat, we didn't ever add a column to that cat. So I don't know if that would have helped him or not, or if he would have recovered on his own. Hard to say. But that's kind of my experience with it. Sorry, I don't have more of a.
And so, how long have you treated those patients with dialysis? It's because it looks like they recovered pretty quickly, I think.
Yeah, they both got a total of 4 sessions over 2 weeks, and that was it.
Okay.
Yeah.
Because I feel like that's one takeaway that I've got from this is that compared to some other toxic AKI, it seems like the prognosis is better and the recovery is faster than what I would expect with some other toxins. Like if you get a severe AKI with ibuprofen, they're going to take longer than that to recover. So it kind of gives some hope. I think I saw Rachel raising her hand. Rachel, do you have a question?
I have a comment, and I was just checking. So obviously, I work at Zoetis Reference Labs as well, and so whenever I hear anything on the listserv or from a friend about one of these, we report it as a adverse event to our company. So some of you have been the victim of my immediate reporting, and I wanted to double check. So, excuse me. From what we've seen with our adverse event reporting, it's when these things are sent out in packaging that has been repackaged by the veterinarian or by Chewy, and not necessarily from Zoetis. So I think that when it is kept in our packaging, it's incredibly hard for any animal to get into and break into. And these are scenarios where they've been repackaged in a container that's easier to open for small animals. So I don't know if you guys have been following that as well as like one of the indicators
No,
of
but
ability to get
that's
into.
actually a great comment because I mean, I feel like it's pretty unusual that cats go into medication in general. And I was really surprised too that I was actually making the comment about a week ago, like, well, maybe they have to rethink the packaging because a cat shouldn't be able to get in the bottle, right? So it's really interesting that you have that feedback that they have been repackaged, maybe in something that is not cat proof or even dog proof. And so that might actually warrant like a warning too to the community that yeah, keep it in the original packaging because that's if not, that's why you can get in more trouble.
Yeah, that's what, and honestly, I am diagnostic lab, so I don't see how that gets worked out and developed. But I did just double check to make sure that this was the information we have heard from the reports. And so I do apologize anytime you guys tell us about anything that has a biopsy report and you said it's on side point or something like that, I always report it. And I do know it might be frustrating for you guys to have to go through the adverse event discussion with our company calling you, but obviously we take it very seriously. So.
I do have a comment about that. If I can say, like, in the
I was
UK,
actually going to invite you to come to the mic because it seems like you have a fair amount of data and you were
yeah,
saying that the blood work changes that Tyler was reporting were pretty common on the poison alpine, right?
yeah, very commonly these cases when they're coming in are hypophosphatemic, hypokalemic, and then they later on become hyperkalemic. Hypocalcemia, pretty common, especially with the renal cases, neutropenia. We're seeing it's usually like a stress hyperglycemia type of situation. So definitely there's lots of blood work changes that are pretty common. Um, as far as the packaging goes, I think it's just really interesting to note that in the UK, it only comes in a blister pack, and they have far fewer exposures, smaller exposures. Whether or not that's related to packaging or not, unknown, but I think it is interesting to note the differences there. And we're starting to try to kind of keep track of that here and see if it makes a difference in our cases too. So I think it's worthwhile to investigate the packaging question for sure.
Well, I mean, it kind of resonates with me too, because like before coming to the US, I was never seeing any ibuprofen toxicity because we don't sell ibuprofen in bottles of 500 caps. Like the typically these medication would come in blister packs and the box wouldn't have more than like 15 to 30 tablets, which obviously decrease the potential exposure to pets.
And individually packed, like this is,
Yep.
this is
And with
absolutely
boosters, yeah.
a US disease that I also haven't encountered during my vet school.
And they're very, very like drawn to this. It seems like especially cats, they're getting in the bottles. We normally wouldn't think they would do that. And when we have an exposure, we often have multiple pets in the same household involved. Like the owner will assume it was the dog because they found it chewed up, but the next day the cat is vomiting and azotemic. So often these cases we're having like multiple pets partake in this apiqual party. So they all seem to really, really like the taste.
Well, I
Yes.
think we can actually congratulate Zoetis on the palatability of those churros.
I asked them about it because I was like, what is it about this that seems to be like crack for cats? But apparently it's like their pork and yeast mixture that they're using for it. That apparently they've started using more for cat meds in general because it's like cats just like are wild for it.
And even in the palatability study they did for dogs, even one of those study dog households broke into the bottle and ate the whole bottle. So from the beginning, it was very, very tasty for them.
All right. Does anybody else
I
have some additional information, has treated some cases, and have some pearls to share with us?
Hey, Cedric, I just wanted to reflect on some of the cases that we've treated here.
Sure.
One dog that we had was about a 9-year-old kind of mid-sized dog that got into a pretty massive dose, unknown dose of Apoquil that went through kind of the initial clinical signs that we were all describing here, developed an anuric grade 5 AKI, and we ended up treating that dog with hemodialysis for about 6 weeks. Had got off of dialysis with and is now has a stage 3 CKD. But recovery is possible for these dogs, and that's obviously worst case scenario where they're going through multiple weeks of hemodialysis and unknown as far as recovery. We didn't have any sort of baseline data for that dog as far as its previous renal function or anything like that. So I guess takeaways would be they can recover. That's a N of 1 for one of the dogs that we treated. The other dog that we treated had a pretty massive ingestion, about almost 60 mg per kg ingestion. It came in quite neurologic, very ataxic, raised third eyelids, was tachycardic. I ended up doing hemoperfusion and hemodialysis in series. And we've got some pretty good data on that as far as clearance. I can't remember the numbers off the top of my head. Shat might know as he's digging through it. I'm kind of doing multiple things today, but that dog ended up doing well. We were able to discharge that dog without an AKI. And I did treat that dog with esmolol. I know Pet Poison is recommending propranolol for a lot of these dogs with their massive tachycardias. I just felt like better control from the heart rate standpoint, if I could fine tune that with my esmolol rather than something that has a much higher or longer half life, we would just be better off. And so that dog actually did really well. And I really do think it highlights when we pick these cases up and when they present to your clinic. And I think the treatment options are going to vary depending on where they are clinically and what their AKI status is as well. So just wanted to kind of put that out there and see if anybody else had any other experiences on that.
I can comment to those values. The dog that Dan was referencing that he treated, we started out not quite as high on the blood levels, and I think that dog was about 3 or 4 hours post ingestion by the time we got started on treatment. And it's about a 30 kg dog. Our initial blood value levels were a little over 10,000 nanograms per mil. And after 9 blood volumes treated, we were still over about 3.5 times over the typical dosing regimen. It was still about 3,580 nanograms per mil, where I think the typical oral and injectable dosings that you see on references are probably closer to, actually, I guess it was more than that, but it was about 500, 600 nanograms per mil for sort of reference of normal dosing values that I saw.
And I think I saw Rachel raising her hand.
So
Yeah.
sorry, not on camera. Just there has been comments. I think Dr. Lister was talking about previous autopsies and having mild ATN on autopsies. So at the International Veterinary Renal Pathology Service Plus, we have looked at 3 of these animals, and that's some of the ones that Emmanuel is presenting in her pictures. So obviously getting fresh tissue is very helpful for being able to diagnose the severity of ATN. It can get a little bit confusing if there's a little bit of autolysis, but also having special stains can help. And then having somebody who reads a lot of kidney can also help your diagnosis. So there was definitive ATN in her cases. We did do electron microscopy on some of these as well. There's nothing really pathognomonic on the EM. It's not like I get to see crystals or large myelin bodies or anything like that. I'm not seeing like huge things that would be pathognomonic for this type of toxicity, but it is good to at least be able to say it's mostly a tubular thing. It's not necessarily hitting the podocytes as much. So if there are samples that are fresh and that you want to send to us, I'm saying this, Dr. Hocamp is also on this call as well. We would be happy to do a second opinion for just grading the degree of acute tubular necrosis. And that is separate than my work from Zoetis. That is a contract work I have with Dr. Hocamp at Texas A&M. So yeah, Dr. Lister, if you have any of those samples and you'd like to let us look at them for grading of the degree of ATN, because I'm pretty sure it's just making sure that all of the features that we see with loss of brush border, all of those things are accounted for in that. But we have not seen anything pathognomonic on EM. We've been looking at the tubules to see if we can find something in the tubular epithelial cells that would be like, yes, something's accumulating here, or we can find like sequestration of material, and we're not seeing any of that. So.
And do you think maybe
So
the degree of acute tubular necrosis can depend also on when the sample was taken? Like, I don't know, let's say that a dog was euthanized very early in the course of disease and they got the sample at that time. This is a dog that was like a few days in the disease. Like,
Yeah, yeah. It also, yes, it would be lovely. Obviously, when we're doing a study design for this to follow it, it would be great to have biopsies to track the ones that recover. So that would be amazing. Obviously, I don't think a lot of people are going to want to have multiple biopsies from their animals. Some of these cats that have had an AKI event, looking at their kidneys a couple years later, it would be very interesting to see if there's going to be scarring that were residual events from this previous intoxication. So, yeah, following it and getting a time point analysis would be very helpful.
So, Rachel, are you thinking that the ATN is due to massive ischemic injury? Would that make sense?
Yeah, so when you get to that point, it could be that it doesn't look strikingly different from other types of ATN. So obviously, when we figured out the melamine cyanuric acid, we had amazing crystals to point to, right? This is just giving us a generic acute tubular necrosis. So is it ischemic? Is there a toxicity that we're just like not seeing inside the cells? We don't know. It's not identifiable yet. But I do think the ATN is quite prominent from the ones that have had to be euthanized and gone to autopsy.
Yeah,
all right,
the couple cat necropsies that I knew about, they were done about 2 or 3 days post exposure, and so they were, I guess, early on, and it like could have been more severe later if they had been necropsy later. But at the 2 to 3 day point, the changes we got back for both cats were just mild, interestingly, and they were like azotemia too high to read.
We've got just a couple minutes left. I was just wondering if is Erica and the Penn team still on? I didn't know if you guys had anything to add. I recall you've been looking at some of the apical talks.
Yeah, I'm here. We did. We are doing a multi-center study, our a resident, and I think you participated, didn't you, Jethro?
I did. I did.
So we actually just got some of the statistics back, and I don't feel like I can speak to it because we haven't gotten deep into it yet. But stay tuned. We're hoping to try to get some information out quickly. I think we have about 52 cases
Wow.
of both cats and dogs.
And do you have any experience with treating these toxicities with the cytosol of that rescue?
Yeah, actually we haven't treated one yet. We've had some referrals where clients couldn't afford to treat, so acute toxicity, acute ingestion. And then we've had some referrals for azotemia, so a few cats that, had a creat of 6, and the referring veterinarian was very, very concerned and sent them in, but ultimately they didn't require renal replacement therapy. So the cases we're seeing have all recovered. We did have one dog as well that, had the signs that have already been described, like hypotension, tachycardia, had a mild AKI, was in the hospital probably for about a week. That dog recovered as well. So I agree with the statement, like these cases, I think can do well. I mean, certainly there's some bad ones for sure, but
I think that's the hard part with all of these toxicities, right? Is that we're dealing with such varied outcomes that really don't seem to perfectly align with the exposure. You have the self decontamination, you have all the decontamination efforts, and the other variabilities of time to intervention and different interventions that are applied. And so it is really frustrating. To know exactly dose and outcome. And so it is something that we reiterate oftentimes to our owners that really time is going to be our best tell for a lot of these patients if they can afford it and give them time to support through it. And ideally, if we can avoid or intervene. I think the one thing that sort of rings true to me throughout all of these is that you do have a lot of these hemodynamic components, and we're struggling with blood volume and how much ischemic injury do we induce in some of these challenging cases. I think we have to balance out in deciding which ones we're treating versus which ones we don't. But it's awesome data you guys have shared. I appreciate it.
I think that the question is more so for decontamination, because like when they are in acute kidney injury severe enough that we're considering renal replacement therapy, and that's not so much, I mean, we have criteria to decide whether we should do it or not, and we know that we'll improve the morbidity, if not the mortality of those patients. Doesn't mean that we cannot treat them conservatively, but at least to me that line is pretty clear. I think what's more difficult is like when we're in that window where we can still decontaminate with hemoperfusion or maybe a combination of hemoperfusion and dialysis. I was just like, is the benefit of my treatment going to outweigh the risks, or am I going to do more damage? I'm still pretty convinced that we have that rare opportunity that we can decontaminate the patient after the toxin has been absorbed, and that, I mean, we would always make a dog vomit when they come in to try to get as much out as we can. And to me, hemoperfusion kind of lines up with that. Like that, the more I can remove early after ingestion, the better outcome I'm kind of looking at, I think, and less damage. Because same, I mean, I got a similar reflection on ibuprofen toxicities. I know some of those, they might have just like a grade 2 or grade 3 AKI, and they will be out of the hospital in a week from now. But how much nephron have they lost in the game? Are they going to develop chronic kidney disease 2 years from now? If you get a 1 year old Labrador that went into a significant dose, are we better trying to remove it and avoid any degree of kidney injury? I mean, not any degree, but at least not an azotomic AKI. They probably lost less nephron reserve with that episode than if we let them develop the AKI, even if it's a non-lethal one. So kind of need to put that into perspective too. Is like how much organ damage are we preventing by removing the toxin? So, but then it's just, yes, it's not because we cannot do it or the people can't afford it that they're not going to do well, but I think it's still on the table in many cases. Oh, Corin, you have a question? Nice to see you.
I was just going to mention one of our cases quickly, just because the point came up on using hemodialysis for decontamination. Because down here in Australia, we still had difficulties with import regulations, so we don't have hemoperfusion down here yet. So we have had one case where we got it about 6 hours after ingestion, a cat, about 43 mg per kg. So we used hemodialysis in an attempt to decontaminate. We haven't sent levels. We collected plenty of samples. We haven't sent them yet. So it's a watch this space for how efficacious it was for the actual toxin removal. But the case did clinically really well. It developed a mild AKI. I believe the peak of the creatinine was in your units about 2.8. Didn't need further hemodialysis for its AKI. And is now non-azotemic following that, and did clinically very well, developed a neutropenia, but none of the other sort of toxic effects. So our clinical experience in that single case was good following prompt hemodialysis with that aim to
Yeah.
decontaminate.
It would definitely be interesting to get the plasma levels of clatinib in that case, because, and again, to reflect on the Emmanuel first slide about the pharmacokinetic data and the protein binding of about 60 to 70%, it's very likely that in huge overdose, it's just not even enough binding sites to reach those 60%. So maybe like the protein binding of the whole burden is actually lower than that, and we have the opportunity to have more free fraction that we can dialyze out. So very very interesting input. Thank you, Corinne. All right, so it looks like we're at the end of the hour. I mean, I don't know about you guys, but I learned a lot today. I mean, I had a great time, great attendance. Like, obviously, it seems like that topic interested way more people than just the extracorporeal community. There's a lot of critical care people, toxicology people. So that Justin Lee was somewhere, like people from poison control. So that was a tremendous attendance, and I love to have like diverse input like that from different specialties. It's very very interesting. Any closing remarks, Jethro?
No, I thought this was amazing.
Yeah.
Getting these different experiences together in one place. I learned so much just, looking at those high levels, 12 to 15 hours after, ingestion in those cats. I mean, that's for me is another line in the sand to treat those guys. Thinking about the transient cytokine storm, comparing and contrasting the different extracorporeal circuit volumes and that manual extracorporeal circuit that you created for that hemoperfusion treatment. That was really interesting, as well as all the descriptions and sharing of the cats that survived their AKIs, even after several weeks with and without extracorporeal therapies. So beautiful sharing. Learned a ton. Hopefully everybody else got a lot out of it. And as always, I mean, reach out to Cedric and I if you guys have more, topics like this that would stimulate this kind of response and attendance. Because there's so much more to talk about. We could talk for another hour or longer, I think, on this topic alone. But this was wonderful. So thanks everybody, and Cedric for organizing this topic today and our guests. That was
Oh,
great.
I was that was very selfish of me. I just wanted to know about all of these things. And again, yeah, I mean, you don't necessarily have to present something or have data to present. If there's just like a topic that you find would be interesting for the community, then we can try to work something out and invite the people that know the most about it, whether they are like a critical care, nephrology, extracorporeal therapies, or some other specialties. I'm sure some people would be happy to join. I still want to have a kind of like free discussions every now and then, but I think a more structured and organized session like today, maybe every month or every 2 months is awesome. So, and definitely it looks like it's attracting a lot of people. So let's do that again.
And this will be recorded and available on the ACVNU site as well. So if you missed anything and want to review it or share it with your colleagues and trainees or other folks that couldn't be here, definitely check that out. The YouTube channel is going to have this on there, usually within a week or so, I think.
Yeah. All right. Have a good day, everybody.
See you in a couple weeks, everyone.
Bye,
Bye.
everyone.
Bye bye.